Hello, everyone, and good evening. It's good to be back. It's 7 p.m. UK time, so this is a different time for us tonight. However, we are here and we are ready to provide you with some details and some possibly new things that you don't know yet. But of course, also we are here to answer some of your questions. And as you know, we are here every single day to support you, to give you an opportunity to meet top fertility experts. And of course, once more, we have another special guest and another fertility expert. This is Dr. Pavel Otevřel, and he is actually from Brno, which is located in Reprofit Clinic, which is located in Brno, Czech Republic. So, hello, Dr. Pavel. How are you feeling tonight?
Okay, nice to be here again. So, strange times, yeah, the COVID era. It's something what we are facing, all of us, too, and hopefully we only wish that it will be getting better in a few weeks. Yeah, so I'm happy that there is a platform like you, and we can share our experience and our feelings maybe and our knowledge. And hopefully my lecture today will be useful for you in these times.
I have no doubt here, so I'm very, very happy and excited to have you back because this is our second, I believe, webinar with you. So thank you already for joining our Stronger Together initiative. Once again, this is our second edition of it. So thank you from whole team for being with us tonight as well. And of course, let me mention that all those events have been brought to you thanks to also our ambassadors and partners. And there's a bunch of people that are supporting this initiative. So huge thanks for their support, constant support, and you can see all of them right here as well. And as you can see, our topic today is definitely interesting. It's definitely not an easy topic as well. So it's implantation failure. Is it just bad luck? But not always. So of course, Dr. Pavel will be talking about it. He will explain most common reasons for it, of course, and afterwards it will be time for your questions. So as always, don't forget to put those in the chat section so that he can answer them for you one by one as well. And remember, it is being recorded, so of course, if you have any issues, I hope not, but if you do, it will be possible for you to have a second option to simply rewatch it. And that is it from me for now. Dr. Pavel, are you ready to begin?
Okay, I am.
Perfect. Go ahead then.
Okay, so again, hello from Brno. For those of you don't know where the Brno is, I could describe it's approximately 2 hours by car from Prague, capital of Czech Republic, and 1.5 hours from Vienna, the capital of Austria. So quite good, reachable. Okay, so my topic today, my talk is about implantation failure, which is, let's say, very challenging and exhausting situation in life of a IVF specialist, and of course, and you know about it, it's a very hard situation in the life of a patient. First of all, what you can imagine with under the name of implantation failure. Simply, implantation failure is a negative pregnancy test after the embryo transfer, of course. The upper level is unexplained and or repeated implantation failure, which is a situation when good quality embryo repeatedly fail to implant, and the definition is that it should be at least 3 times, I mean repeated implantation failure, at least 3 times without the reason we know. It's as I told you previously, it's a very challenging situation. It's a frustrating situation, and my talk should show you the way of thinking of clinician facing together with the patient to this situation. The implantation is very complicated process. Yeah, so in literature you can find the name embryonic maternal crosstalk, and there is a lot of different aspects, and on all players on the field must play for 100%. Even one missing player, one missing aspect could negatively affect all the process. And we are able to open only very small part about this process. Our knowledge is limited. We know about it, and the development on a scientific field is still going on. Yeah, but basically we can split the problem on the two parts: the embryo problem and the endometrium or uterus problem. Yeah, so if we are looking for the reason why, we should start to investigate both sides. It's told in the literature that very likely the problem of implantation, the reason of implantation failure was in the embryo. And if we are talking about the embryo, we are talking about the genetic profile of the embryo. Approximately 60-70% of implantation failure has a reason in genetic incompetence of embryo. The maternal side, the recipient side, is also important for sure, and we have a lot of difficult fields we could be focused on, and we could investigate. Imagine the situation: the last or previous implantation failed. My first question must be, how old was the egg from which the embryo was created? Because the age of the egg is the most important thing. And as you can see in this diagram, even in the group of young, healthy women, approximately 1/4 of embryos carry any serious genetic problem, and these embryos are convinced not to implant. And with increasing age, we can see that this ratio, this proportion is increasing. If you can simply in practice, we can talk about the typical IVF patient, 39 years old, implantation failure. Approximately it was 50-50. Yeah? The reason why the last embryo didn't implant was probably in embryo, in this particular embryo, with the probability 50-50. Yeah. So if we would like to improve the embryo side, we should recommend the genetic testing of embryo. And what is it about on this slide? Sorry. The idea of genetic testing is to take a few cells from the embryo. Mostly it's done on embryo 5 or 6 days old. And we take and investigate these cells and their DNA profile as a representative of whole embryo. You can see that at day 5, the embryo is divided into two parts. The blue cells is a so-called trophoblast, future placenta. Now the pink cells in the middle is a so-called embryoblast, future baby, future fetus. And if we will take a few cells from the trophoblast, we suppose, and the idea of the method is that this cluster of cells is a representative of all the embryo, represents it. Technically, it must be mechanically by laser, you can see here, yeah, by laser removed. This process is very gentle. The staff doing this must be very, very educated and skilled. You have a have to have a well set learning curve in the lab, but generally worldwide it's considered to be quite safe part of the process. But when it looks perfect. Yeah, we will obtain the information about the embryo. Perfect. We know about embryo everything. But, and it is why I'm trying to explain it. We have to ask, what if we receive false positive result? What if the representative lies and shows only part of the truth? What if we did harm the embryo by mechanical manipulation? And what if, and it's very, very important question, and it's discussed on scientific field for many years. What if we obtain good result, which is true, the embryo is the result shows that the embryo is bad, we will throw the embryo to the bin, but this particular embryo would be implanted because the embryo is able to heal itself. It is a legitimate question. How this question you can find in the literature, in the scientific literature. How many children was lost in the trash bin in the embryonic stage? Yeah, so the PGTA is very good and sophisticated method, and there is proven that the benefits of this method prevail for sure in a patient of age group 40 plus, and very likely in patients older than 37. In this group of patients, it brings less futile transfers, less miscarriage appear, and of course it could shorter time to pregnancy. So please note that PGTA is not the holy grail. PGTA or PGT generally is not able to improve the embryo quality. It's a basis logically. PGT is not able to increase the implantation chance of the particular embryo, but PGTA is able to provide information regarding the genetic profile of the particular embryo with very high accuracy. Nowadays, there are two almost new ways of investigation on this topic. One of this field is non-invasive PGT, which means that we are investigating free DNA from the medium, cultivating medium, fluid in the dish. But there is a lot of questions and a lot of limits. And of course, the second field of investigation is time-lapse recording. Yeah, it means we can predict. We can maybe in future we will be able to predict implantation chances of embryo according to movie, according to a record of the early embryo development. This time-lapse incubators are offered from many IVF facilities because we are very close to the to good results, but still it is not possible to tell you that the time-lapse incubators are any huge improvement. Yeah, it's still in the development. It could show us another aspects of embryo development and probably about their genetic profile, but it is not for 100% clear if it's really helpful. Yes, so let's sum up the embryo side. PGT and morphokinetics, time-lapse incubator. It could provide us more information about the embryo site. We can exclude the embryo with very bad genetic profile, genetics, but be careful and do it only in case there you can find a really serious reason to do it. Let's now focus on the maternal side. So it's about what could be tested in case of implantation failure when the reason is more likely on endometrium. In practice, you can imagine the situation, the last embryo was genetically tested, and despite this, the implantation failure happened. Yeah? What we can test, what we can recommend. Maybe easy, maybe difficult. Lifestyle changes. It's we can change our habits. We can change our lifestyle aspects. Some of them reduce weight, reduce fat in the body, stop smoking. Everything this could negatively affect the egg quality. The thyroid gland function should be okay, and now very promising seems to be supplementation of some vitamins, and especially folic acid, vitamin D, and coenzyme Q10. There is a lot of scientific proofs now that these three substances are useful in prevention of miscarriage and improving the implantation rate. Yeah. So what we are not able to improve is age, because as you saw in the previous slides, the age is really the highest playing card we are playing with. Cavity shape and tubes. Mostly after implantation failures, it's recommendable to check the cavity, the situation in the cavity. Mostly the hysteroscopy is recommended, which is a controlling of the cavity shape by camera. And our goal is to exclude the fibroids, especially fibroids located closely underneath the endometrium. They could negatively affect all the environment. To exclude and remove polyps, to exclude and to treat in case of confirmation the invisible by camera visible inflammation, and to exclude the cavity adhesions, which is very hostile situation in the cavity. Yeah, because cavity adhesions are a really serious obstacle for implantation. If the laparoscopy is recommended, the goal should be to exclude damaged tubes and to remove such a tubes, because if the tubes are damaged and there is a fluid collected in the tube for a long time, the presence of such a chronic inflammation could negatively affect the environment in the cavity. There could be the leak of fluid into the cavity, and it could kill the embryo directly. Yeah. So, and there is a few very nice Scandinavian studies showing that the removal of a damaged tube could double the chances of successful implantation in the next cycle. It should be recommended if there is a suspicion by ultrasound that there is a water or fluid generally in the tube. And a very popular chapter of the investigation. It's an investigation of implantation window. On the picture, on the left side of the slide, you can find the typical and normal situation in approximately 45% of ladies. Normally, the endometrium needs to be 5 full days. It is 120 hours under the influence of progesterone, because in human there is no pregnancy without progesterone. Progesterone is a very important hormone, you know. But the timing is important. How many hours the endometrium need to be ready? And standardly, it's 120 hours. Yeah, the first contact of endometrium with progesterone. It could be the natural progesterone after ovulation. It could be vaginal progesterone. It could be progesterone in oil. And after 5 days, the endometrium is on the top of receptivity. In practice, because probably you have undergone already the frozen embryo transfer, so I suppose you have your own experience. You can imagine that you are asked to take the first progesterone on Monday morning, and you will be asked to come over the clinic for the embryo transfer on Saturday morning. Yeah, you can count. It's 5 days, 5 full days, 120 hours. But there is approximately 15% of patients, they have a genetically different this timing. Yeah, it could be less or more than 120 hours. Yeah, and this genetically done timing could be investigated. Yeah, it's quite expensive examination. It's done from the piece of the tissue, yeah, removed from the cavity. The most popular and most spread worldwide is a so-called ERA test, ERA test done in Spain. Yeah, and because it's quite expensive, but not only because of the expensivity, but you can find quite loud voice, scientific voice, that with doubt that this test of implantation window couldn't show the whole truth. Yeah, so despite it looks very to be very good and very promising, and we clinicians, we have experience that it's really helpful, you can find the lot of questions regarding the results, and it is why this implantation window test is not the first choice test. Yeah, and now our topic today is a repeated implantation failure, or at least one implantation failure. And if we are talking about this group of patient with history of implantation failure, okay, this test should be considered. And by my experience, after at least 2 unexplained failures, it should be recommended. The environment of the uterine cavity is a very complex locus in the body. There should be considered to test the environment in group of implantation failure patients, and we can exclude the infections, but note that the infections in the uterine cavity are very rare. Cervical infections, because cervix have a direct connection with vagina, is more common, cervical infections, but on the other side, there is a low relationship between cervical infection and implantation. And please note that bacteria in uterine cavity have a very special environment to live. And it is not easy to simply do the smear in your gynecologist and to do the smear and cultivate the bacteria from cavity in standard laboratory. Yeah, the results obtained from such a simple smear are non-complete, are unlimited. So if there is any suspicion for uterine infection, I mean cavity infection, it's better to use a genetic test instead. Microbiome. It's not all. I'm not talking about the slide is about the microbiome in uterine cavity, of course, but generally in the body there is a lot of different microbiomes, and that now this gut bowel microbiome, mouth microbiome, this investigation on microbiomes looks very promising, and probably the microbiomes play more important role than we estimated. And generally, the microbiome in the uterine cavity must be embryo protective and not non-inflammatory and non-hostile to embryo. It could be tested. It could be tested by genetical test from the tissue obtained, removed from the cavity. Again, it is not the first choice test, but it should be considered in the investigation of a repeatedly failed patient. And let's partly go back to window of implantation. You know, the progesterone hormone is absolutely essential for successful implantation. Please note that high progesterone or progesterone must be high enough at the time of implantation and later, not before. If there is a preterm or premature progesterone elevation 7 days before the embryo transfer, it could have a detrimental impact. Yeah, so it is recommended to test progesterone twice in the cycle. Yeah. Before embryo transfer, talking about the timing 7 days before the embryo transfer, and our goal, our wish, is to have a progesterone as low as possible. If the progesterone is too high, better to consider not to do embryo transfer. And the opposite side, after embryo transfer, we need to have a high progesterone. Yeah, it's good to test it on day of embryo transfer and 7 days later. And if there is any lower or almost low the level, better to increase the substitution. I don't want to give you any strict numbers, strict recommendation, because there is again lot of aspects. We know that natural progesterone is changing during the day. Yeah, there is a huge amplitudes during the day. So it must be taken into the consideration. Only I would, if your clinician is open to test it, I would recommend it. Yeah. Again, please note that we are talking about the specific situation about the patient with repeated implantation failure. So it makes sense to be focused on such a detail, yeah, in this group of patients. And my almost the last slide. It's a slide focused on immunity. As you can see, the slide is very brief. And on this left side, you can see why. This esteemed organization, HFAEA, last year, 2019, provided this traffic light chart, and you can see that reproductive immunology tests and treatments belongs in the red part, where no evidence of effectiveness and safety is published. Please, I would like to underline, I'm advocating for immunity testing. Yeah, but I would like simply explain you that this topic is so complicated and so questionable that it is not possible to explain it now on this field. Simply, what could be tested by genetic test, different test. Yeah? We can test directly the tissue from the cavity, from endometrium. We can exclude the hostile environment. We can test peripheral normal blood immunity from normal blood sample parameters. There is a lot of question if the peripheral blood shows reality in the cavity. Yeah, we can test the mutual incompatibility between mother and fetus, or biological mother and biological father. Yeah, but as you know, maybe, and I know it for sure, there is a limited amount of experienced specialists, a limited amount of laboratories that are able to comment their results, and moreover, all the treatment recommended on reproductive immunity, it's done mostly on personal experience of specialists rather than evidence-based statistics. So immunity is a huge and challenging topic, but not possible to recommend it now or not recommend it now on this session. My first slide. Almost all of you know that the way to pregnancy is mostly zigzag and steep way, and only sometimes we can find a beautiful castle on the top. But from my experience, and it's my approach and our approach here and in our clinic, it's written here in the middle column. Please, after first implantation failure, stay calm. Yeah, the nature of human reproduction is low effectiveness. Yeah, if you can, I saw a very nice lecture about the mice embryo. Yeah, and there was a 99 from 100 mice embryos implanted. It's extremely high implantation in mice, but we are human. We are human, and unfortunately, the nature of human reproduction is low implantation. It is not disease; it's natural. Yeah, stay calm. Implantation failure number two. It's still can be the only bad luck. Believe your specialist, believe your doctor. After third implantation failure, it's it is not. It could be the first sign that something wrong is in your body. And starting from implantation failure number three, it makes sense to consider the development and to investigation of both sides, embryo side and mother's side. Yeah. So of course, I can imagine that there are couples or people, they prefer to do all possible investigation before the first embryo transfer even. But from the nature of human reproduction, it is probably wasting time and money. Yeah, I feel that this recommendation is very, I don't know, my English is poor for this sensitive explanation, but I feel it could be exhausting and very disappointing to undergo one or two mistransfers. Yeah, but from the rational approach, it makes sense. Try it twice and investigate later. Yeah, fingers crossed for you. Yeah, all of you. It was my lecture.
And excellent. Thank you so much for that presentation, for so many details, and of course for all your recommendations. Well, as you can see, there are plenty of questions ready for you. So I guess we can start with our Q&A session. And so everyone, if you have any questions, just go ahead and type those in the chat section. Okay? And as I mentioned, there are plenty of those ready. So let's have a look at the first question that we received. I am 42 and I feel the questions around PGTA are still very valid over 40, if not more. So as I don't have embryos to waste, if embryo result is poor but could potentially correct itself. So I am really interested to know why PGTA is recommended more so for over 40.
So maybe I can answer on a particular case. So if the patient, and doesn't matter if she is 40 plus or under 40, if the patient has one embryo only of good shape, I would recommend to transfer it without genetic testing. Yeah. So because as I showed in my slides, the test is not improving the embryo quality of particular embryo. And why it's recommended for 40 plus, it's based on the word statistics. If you do you have a design of the study and you compare the different age groups, you can find the huge improvement if you compare patient 40 plus and with and without PGTA, you can find a huge improvement in the patients group 40 plus with PGT. But it is a statistic. It is not picture of one particular embryo. Yes, so it's simply because we will in such an approach we will do the PGTA. We simply very likely exclude bad embryos. This embryo transfer are not performed, and it looks like the embryo transfer of genetically tested embryos provides better results. Yeah, so it is why you can find the recommendation that 40 plus have a profit from PGTA. But if you are a patient in my office, you have only one embryo, and you are asking me if to do genetic testing or not. My recommendation would be not to do it. Do the embryo transfer. Yeah.
All right. Wonderful. Thank you so much. And well, actually, there is a follow-up, okay, from the very same patient. So let me go straight to that. It's very similar to the previous question. So would you recommend the same rational approach for all ages, or only stay calm and believe if you are under 40? Is there a different rational approach over 40 to begin investigation sooner? I have one fat implantation considering and
Yes,
want children.
there is one point of view which must be taken into the consideration, and this point of view is that patient in 40 over 40 will have probably one embryo only. I can simplify this situation, yeah, in my example. Yes, if there is a patient over 40, we have to be happy that this patient have one perfect embryo, and for this embryo we should do maximum. Yes, I would agree. I agree that it could be taken into the account and consider if the patient is older or younger. Of course, to be patient and stay calm, it's more recommendable in younger age group than in the aged ladies. Of course, I would agree. Yes.
All right, wonderful. Thank you so much for the clarification and your recommendations to this. And of course, there's a thank you from the patient for you as well. Next question, very straightforward. So, hi, is taking 50 milligrams of ubiquinol helpful?
Yes, it is.
All right, simple question and simple answer to that. Thank you so much for that. Next question is, so for a patient who had several implantation failures, 6 transfers, would you test the implantation window in your clinic in Brno?
Yeah, yes, we do it. We do it. Generally, we are trying to arrange more tests on the one day, because if the patient is coming over here for the implantation window test, and if there is any ratio to do rational reason to do more tests, we are trying to do it on one day. Yes, but yes, we do it, because I mentioned, maybe it could be confusing. I mentioned in my lecture that the tests are done in Spain, but the laboratory is in the Spain. The tissue samples could be removed in any facility worldwide, and we and I have to appreciate the service of the Spain laboratory, because it's very easy to send the sample, tissue sample, to the lab, and the communication and paperwork is very useful and user friendly. Yeah, so it is information for regarding the ERA test, and it's valid worldwide. Yes, patient could undergo this sampling in her facility, and the sample will be sent to Spain.
All right, wonderful. Thank you so much once more for that. Actually, there is another question in regards to ubiquinol and CoQ10. So, what is the ideal dose of ubiquinol? How much better is it than CoQ10?
Yeah,
ubiquinol?
it's a reduced form. So there is I'm not biochemical specialist, but it is a in the body there are three forms of coenzyme Q10, and ubiquinol is the most effective in the utilization of energy. Yeah, so because simply the you can imagine the uh, egg like a battery which is laying 40 years in the garage. Yeah, there is some energy inside, but not too much, and you have to recharge it. And ubiquinol is most effective in this adding the energy into the egg. Yeah, so if you compare all three different chemical structures of coenzyme Q, they said ubiquinol seems to be most effective.
Okay, understood, of course. And actually, there are follow-ups in regards to ubiquinol CoQ10. So, is CoQ10 recommended for
Yes,
male?
yes, it is a similar with sperm.
Okay, wonderful. Thank
Yeah,
you. And can I?
sperm and DNA, the DNA breaks. Yes, so it's proven on both sexes, male and females.
All right, excellent. And can I
Yes, yes,
continue?
you can continue ubiquinol while doing the stimulation. There is no negative impact on.
Wonderful, thank you. And actually, there is another question. On vitamin D3, 4,000 IU CoQ10 for 400 milligrams, vitamin B1, and Pregnacare, sorry, max prenatal vitamins, all good for donated embryo, frozen embryo transfers.
Yeah, question is about the coenzyme Q10. Yeah, vitamin D3 for sure, at least 2,000 per day. Yeah, so approximately 4,000 looks better to be better. Coenzyme Q10 is questionable in donated embryos because it's my knowledge. Maybe I don't know everything, yeah, but my knowledge is that the most important effect is on the reproductive cells quality, sperm and eggs. And in this described question it is about already finished embryo. Yeah, so vitamin D for sure, B for sure, coenzyme Q10 I don't know.
All right, excellent. Thank you so much for that advice. And we will go for the next question. So, do you have any advice how to prepare for frozen embryo transfer?
Yeah. So my experience is that if there if the patient lady is ovulating, I would rather recommend to do embryo transfer, frozen embryo transfer here in modified natural cycle, because there is evidence that natural yellow body, corpus luteum, yellow body, if there is a present yellow body on ovary in the ovary, the outcome is better. There is a less or low amount of miscarriage. So if there is a possibility to do it after natural or triggered ovulation, I would prefer it. I would recommend to test progesterone level before and after. Yeah, and I think it's a most popular and evidence-based supported approach. On other hand, this approach is not comfortable for patient undergoing long distance treatment. Yeah, because it needs more ultrasound control, more blood samples, and it could be time consuming, and it could be not comfortable with communication. So it's perfect for local patients undergoing the frozen embryo transfer preparation in their country, where is no need to travel to communicate via phone. So it's my remark only. I'm not talking about the medical approach. From medical point of view, natural cycle better, but from the my practice, I see that it could be more complicated to set natural cycle adequately long distance. Yeah.
All right. Again, thank you so much for your question and, of course, for your advice, your recommendations on that. And we will go back to the question when it comes to D3. Okay, vitamin D3 be take. So can
Yeah,
it be taken continuously,
yeah,
or is it
yeah.
necessary to take a
It
break?
depends on the sunshine. Yeah. So in winter time, for sure could be done taken continuously 2000 4000. If there is a lot of sunshine where you live, I think 1000 or 2000 is good. And if and this low amount, talking about 1000 a day, could be taken continuously with no detrimental impact.
All right, understood. Thank you so much once again for that. Let's have a look, of course, at the next question. So, what could we do to prevent immunity issues? Lifestyle?
Talking about the reproductive immunity, there is no possibility how you as a patient are able to affect it positively or negatively. Yeah. So the reproductive immunity is so specialized part of immunity that I don't think that your lifestyle or something like this could improve your immunity. Yeah. So there is no easy way, and if there is a necessary to correct immunity, it must be unfortunately done by steroids or immunoglobulins or so. No, I don't know about any easy way how to do it yourself.
All right. Of course, understood. Thank you so much for that explanation. Next question is on prednisone. So, what's your opinion in general and specifically for women with high TSH level -3? I've read that prednisone interacts with medicines for underactive thyroid. Besides the number of prednisone side effects and lack of firm evidence raise my concerns.
I don't think that the prednisone is it's good to take if only TSH is high. Yeah. On other side, if you will take 5 milligrams per day only, there is almost no side effects. So it is not about the side effects. It is if it could be over treatment or not. I think that it makes sense to take it. Talking about the thyroid gland issues, if there is antibodies against thyroid gland, in such a case, it could be considered, but I don't think it's a standard treatment. Yeah. So if I should answer by one word, I think no. TSH elevation is not a reason to take prednisone.
All right. Again, thank you so much for this. Next question is also ready. So I've done 2 egg collections, and the long protocol produced almost double as many eggs as the short protocol. So 34 versus 18. Now I'm looking for a new clinic, but some only do the short protocol. Should I turn them down right away or be open to try a short protocol again?
Mhm. So, long protocol and 34x. In long protocol, there there is a very high risk of hyperstimulation in comparison with short protocol, and very likely uh, you will need any prevention of hyperstimulation syndrome. So I can answer you in different ways. I would be afraid of long protocol because of the hyperstimulation. For the fresh transfer, uh, very probably there would be not possible to do the fresh transfer in long protocol. It must be all embryos frozen. And generally, I would be happy with 18x. Yeah, so depends what is your goal. If your goal is to be pregnant and to have embryos of good quality, I would be happy with short protocol and 18x. If, and I admit that there could be a reason for this. If you would like to have edge as much X as possible, I would go with the long protocol and freeze all strategy. But if I can imagine you in my office talking about what to do, and we in the in Reprofit clinic we are open to do both protocols, long and short. My first question would be, how was the maturation and the quality of eggs? And I would like to do the decision making according to the egg quality. If you had very good eggs in short protocol, I would be happy with 18 eggs with short protocol. If the quality was better in long protocol, embryo and egg quality was better in long protocol, I would agree with long protocol with the all possible prevention of hyperstimulation. Yeah. So my first choice protocol is short, but if we will be able to find the reason why long, why not? Quite complicated answer, but yeah.
Of
That,
course. All right. Thank you so much. Yes. So you would definitely need to look at it more thoroughly, I guess, as well. But of course, there's a thank you from the patient. And thank you, of course, for that. We will go back to the previous patient, okay? As this is in regards to the question about prednisone, okay? So there is a follow up, okay? So the reason for prednisone is TH1, TH2 imbalance. The dosage of 20 milligrams daily looks rather scary.
okay, so if a TH1 activity prevails, it is the reason why to take prednisone. And for these reasons, 2 milligrams per day is too small amount. It must be recommended 20, at least 10, but my experience is that 20 is correct dose, and you should take some pills to protect stomach ache and inflammation of the stomach. Yeah, so yes, I would agree with this dosage in this specific diagnosis.
All right, wonderful. Thank you so much for yet another advice on that. Okay, next question is also ready right here. So I'm a patient of your clinic. I had one unsuccessful embryo transfer with fresh embryo. Now I'm waiting to do second embryo transfer. My endometrium thickness is quite thin on the day of the ovulation, 6-7 millimeters, but I have regular cycles and ovulations. What do you recommend is natural cycle with few days estrogen support right before ovulation is a good idea.
The question is about the combination of natural cycle and addition of estrogen in natural cycle. Yes, yes. I think we should continue with natural cycle. Probably you will receive Ovitrel on 2 days before your ovulation, and because in the endometrium there are a receptor for LH, we know that Ovitrel could add 1 millimeter of thickness to endometrium. So if your finding is on the edge between 6 and 7, I would agree to use Ovitrel for sure. And if you will take 2 milligrams of estradiol after before ovulation and also the after ovulation, it could help. Why not? Yeah, so I would be happy with endometrium 6 or 7 millimeters in a natural cycle. It could be modified by additional medication. Yes, please remind it while you will be discussing this issue with us before your ovulation.
And excellent. Thank you so much once again for that, of course, as well. And next question is when would you recommend the use of intralipids?
Basically, there are two approaches. The one approach is to use intralipid only in case there is a clear reason, clear immunity disbalance. Talking about NK cells issue. Yeah, so in this group of patient, it looks to be clear. Yeah, elevated NK cells, repeated implantation failure. What we can do? We can do some experience based treatment, immunoglobulins, scratching, prednisone. Okay, and the second possible approach to use intralipid without clear diagnosis, just in case in patient with repeated implantation failure. So here in the Reprofit, we recommend intralipids only in case we know the diagnosis, the immunity issue.
All right. And once more, thank you so much for this question and for your help. And of course, there's a thank you from the patient for you. Okay. And let's have a look. Of course, there are more questions coming up. So let's have a look at the next one. So, out of interest, after a chemical miscarriage at 5 weeks from adopted embryo frozen embryo transfer, would you add anything to protocol other than the estrofen and utrogestin and folic acid?
Mhm. If it was the one and the first miscarriage only in your life, I wouldn't change anything. Simply continue with the same protocol.
All right. Oh, understood, of course, perfectly. So thank you so much for that. Next question is, so just to check I have understood correctly, should progesterone be tested 7 days before transfer, on day of transfer, and 7 days after transfer with fresh transfer and frozen transfer?
Yes, 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 because this premature elevation is important in both kinds of treatments. Yeah. So standardly, and you can find a lot of clinics, they implemented this progesterone control in their standard protocols. That on the day now, let's discuss the stimulation, ovarian stimulation, and the fresh embryo transfer. In this particular treatment, it's recommended to check progesterone level on day of the trigger shot. Yeah, and you can find the clinics, they cancel fresh embryo transfer if progesterone level on day of trigger shot is higher than any number. I don't want to provide any numbers, yeah, because it depends on the lab and so. Yeah, and again, and we need as low as possible. And again, if this patient we are talking about undergoing ovarian stimulation, it's also the patient with repeated implantation failure. You should check the protocol also after on day of embryo transfer and after embryo transfer. Yeah, that's my comment for fresh embryo transfer. And talking about frozen embryo transfer, again, very probably we are talking about the previously failed patient. So we have to check progesterone approximately 1 day before the patient will start to take progesterone. Yeah, 1 day before, and again, as low as possible is better. And on day of embryo transfer, because it's very easy in practice, because patient is here at the clinic, so why not to check the easy blood test. And again 7 days after. Yes, you understood correctly. Doesn't matter if the protocol is fresh transfer or frozen transfer.
All right. Okay, perfect. Understood perfectly as well. But actually, sorry, there is a follow-up from Karen, so let me go straight to that one. If the level of progesterone is too high when checked on day of trigger, can trigger an egg collection go ahead, but just not transfer?
Yes, egg collection will continue. It's only about the endometrium. Yeah, so the collection will be performed, but embryos must be frozen.
All right, perfect. Thank you so much. Well, actually, there is a follow-up from the previous question, okay? So, patient, of course. So just let me go back to that one. It's from Kim. It's in regards to sorry, just let me okay, yeah. So it was the second miscarriage after 5 weeks. First was natural pregnancy, second was adopted embryo, and the first cycle with Reprofit. And HCG only got to 54 on the frozen donated embryo.
Yeah. I think it is a time to start investigation.
Yeah. All right, understood. Thank you.
And my concern is, despite the implantation apparently happened, there is still the reason to do the receptivity test. Yeah, because the miscarriage in the biochemical stage, biochemical pregnancy, could be caused also by asynchrony between endometrium and embryo. Yeah, so only I do not recommend ERA test, endometrium receptivity test, only in case the patient has a history of clinical pregnancy. Yeah, so it means the patient underwent frozen embryo transfer, doesn't matter when, yeah, many years ago. Yeah, and there will be the visible embryo on the screen on the ultrasound. Embryo successfully implanted and was visible on the ultrasound control. We call it clinical pregnancy, and in such a case, it is not necessary to do additionally endometrium receptivity test in Spain. But if we are talking about the biochemical pregnancy, the reason to do ERA test is that there is a reason to do ERA test. What test would you do? Probably my first suggestion should be to next time to transfer genetically tested embryo. So first, I would recommend you to do the genetically tested embryo, because despite the embryo, the adopted embryo is created from cells of donor, male donor and female donor. Despite this, there is a approximately 20% risk that the embryo is not genetically correct. Yeah, so I would recommend you to go again with genetically tested embryo, and on your side, I would consider ERA test and immunity test, but I don't know your case now widely, so I could recommend you generally.
All right. And of course, that's perfectly understandable. So, still, thank you so much for that advice, your recommendations. Okay, next question is up. So, do you recommend any specific supplements to a female undergoing egg donation? This was a very interesting and useful presentation. Thank you.
Coenzyme, vitamin D and folic acid. That's it. If you are normal, if you have a normal lifestyle, normal food, you are not vegetarian, and so I would recommend you simply this supplementation. Well, vitamin D, yeah. So because it was a big step in IVF 3 or 4 years ago, because there was an investigation on vitamin D in connection with pregnancy performed, and surprisingly, vitamin D plays more role in the body than we thought before. Yeah, so vitamin D and folic acid, nothing else.
And excellent. Thank you so much for that once again. And would you recommend the same steps for failed egg donation, frozen embryo transfer after first time calm, after second stay calm, after third consider
Yes.
additional testing?
Yeah, sure. Yes.
All right, that's the way to do it. And thank you so much for that. Okay, and regarding repeated failure of implantation, what is your opinion on embryo glue and assisted hatching?
Mm-hmm. Yes. I'm laughing because before our talk today, I had a dialogue with our researcher here. We have a here at the clinic we have a department of science, and Dr. Holubcová, which is very experienced researcher, published in Nature journal. Yeah, and we were talking about this topic: embryo glue and assisted hatching. Where, when, and why? So embryo glue is a very promising treatment. It could help, but we don't know for whom. Yeah, there is more findings, more investigations on hyaluronic acid, and we more and more know that the embryo needs this acid for your implantation, but we have no test available to distinguish which patient really need it and which patient doesn't. Yeah. Yes, it is taken into the consideration, and with if we are thinking about what to recommend in the next cycle, it is one of the possible recommendation. And I didn't mention it in my lecture because we don't know for whom it is. Yes. So yes, something is on it. And assisted hatching, we the assisted hatching is probably the natural selection criterium for implantation, and very probably the embryo which is not able to hatch naturally is it is probably embryo which is convinced not to implant from any reason. Yeah, so assisted hatching probably doesn't improve implantation rate, but for your knowledge, I have to add the information that all embryos frozen are artificially hatched because the assisted hatching is a part of the technical performance of freezing embryos. So you can count that all your frozen embryo transfer are done with hatched, assisted, artificially hatched embryos. And in case of fresh embryo transfer, there is a habit or a recommendation that we will do assisted hatching in case that the zona, the shell on the embryo is too thick. So we can do and we proactively recommend you assisted hatching. But generally, probably assisted hatching is not important, and probably, or not probably, there is evidence that to do assisted hatching routinely doesn't improve outcomes. Yeah, so assisted hatching, no. Embryo glue, very probably yes.
Wonderful. Thank you for summing up this one as well. And we will be slowly finishing, okay? There are like few questions left, okay? So let's have a look at the next one. I was diagnosed with a heart-shaped uterus 3-4 millimeters fundus. Could this cause a problem for a successful implantation?
By my experience and knowledge, not. Yeah, there is no it is not an important aspect. Yeah, this kind of T-shaped or heart-shaped, T-shape maybe, heart-shaped no negative effect.
All right. Again, thank you so much for that clarification. And do you believe you can improve your egg quality? Some doctors believe in supplements and lifestyle changes you can do this. What is your opinion?
Yeah, yes, coenzyme Q10. It was about it looks to be the most promising supplementation, but it is to make eggs younger, to find the way how to improve egg quality. It is the holy grail of IVF specialists. Yeah? We we were asking by some journal what as a person, as a IVF specialist, would we wish the most, and we mostly answered that we would like to we would like to find the knowledge how to make eggs younger. Yeah, yeah, coenzyme Q10. I don't know about anything else.
And once again, thank you so much for that. Okay. Next question is, so I have had an adopted PGTA tested frozen embryo transfer at your clinic and it was a failure. How many failures normal with tested embryos? When should I start to panic? I've heard already Iran.
It's different. It's different situation. It is a maximum what we can do on the embryo side. Yeah? Adopted embryo, young people. I mean donors, young donors. Embryo will be selected. Embryo will survive freezing thawing. Embryo was genetically tested. It is maximum what we could do. if there was an implantation failure despite this effort on embryo side, I think it could be the time to start to think about, let's say, ERA test. And you have had already ERA test, so additional tests.
All right.
Don't be panic. Yeah. So not now.
Not yet, at least. Yeah,
Not
it's
yet.
all good. You are
Not
able
yet.
to
Not yet.
still
Not yet.
check some other things. All right. And of course, there's a thank you from the patient right here for you. Thank you so much. Okay. Let's have a look. Next question is right here. What do you think about using aspirin before and after frozen embryo transfer?
Yeah. So it is exactly what you could see on my traffic light slide. Yeah. So it is exactly that the aspirin is used very widely. It's my favorite drug, to be honest, in a patient with implantation failure. I mean, and if you will find the big statistics, there is no evidence that the aspirin is improving outcome. But because the only very low dose is normally used, 50 to 100 maximum per milligrams per day, it's very safe. We have to exclude the allergy patient. They are allergic to aspirin. They are not allowed to use it. But if the patient is allowed to use it, and it's so easy approach that I would recommend it before and after.
All right. Wonderful. Thank you so much yet again for another question, and of course, as your advice and answer. Next question. So, could propranolol taking for a long time affect the quality?
Propranolol, I think it is a medication against the high blood pressure. I'm not sure if the propranolol is for blood pressure treatment. Propranolol. To be honest, I don't. Yeah. No. There is this kind of beta blockers are safe for
All right.
embryo and for egg.
All right. Wonderful. Thank you so much for the clarification. Next question is also right. So, how soon starting IVF treatment should thyroid be checked? I had it checked twice this year, and TSH was 2.59. Then reduced to 243. However, antibodies were not checked. Are these levels okay for treatment? And should I have antibodies tested prior to next?
It should be checked approximately 6 weeks before, because in case of some finding of some pathology or disbalance, it takes approximately 4 to 6 weeks to correct it. So it is why 6 weeks before. And the TSH is very rough test. Better to combine it with free thyroxine and antibodies. But I know from my practice that the anti-TPO and FT4 tests are not easily reachable in some countries. The GP or gynecologist is not open to test it, so we have to be happy to accept TSH only. But if there is a possibility to test all the triplet, TSH, anti-TPO, and FT4, so in such a case, I would appreciate it. And the consideration and recommendation about the possible treatment or supplementation is better to done on result of all three hormones.
All right, understood. And as you can see, there is a follow-up, so I just wanted you to see straight away. Does your clinic help with correcting if needed or need to see own GP? They were reluctant even when was above optimum level.
We are happy to recommend you, because mostly only in case sometimes we randomly explore the patient with really serious disease of thyroid gland. Yeah, patient haven't known about it until now. Patient has no problem, and we recommend to do it because of the IVF. And surprisingly, we realize that there is a serious problem. In such a case, we recommend to contact GP and to solve it with GP. But if it's only correction in the normal range, we will recommend the doses of supplementation ourselves.
And excellent. Thank you so much for the clarification from uh, from Karen as well. And as you can see, she is very happy that you have been able to advise her. And there are like 3 questions left, and we will be finishing. Okay, so let me have a look at the next question. So, is there any difference between infralipid and lipid?
I don't think so. I think it's the same. It's the same drug, same solution. Maybe the difference will be in concentration. Yeah. You have to check the label. Yeah. So the drug inside must be intralipid 20% solution. I think it will be the same.
And thanks a million for that one as well. Next question is the effect of vitral and decapeptyl the same after trigger. What happens to the eggs from trigger to retrieval? What could be done to get more mature eggs?
It is the different issue, but it's very important and interesting difference. Uh, the effect on maturation is the same. The difference is that the ovitriol is able to cause LH elevation in blood directly, because ovitriol it is LH. So you will have a LH level peak immediately in the blood directly from ovitriol. And decapeptyl function is via hypophysis. So first, decapeptyl trigger the production of LH in hypophysis, and hypophysis will product the peak in the blood. So there are interstep in this process. And the problem could be if the hypophysis is not working optimally. In such a case, the peak of LH is not high enough and decapeptyl is not working. Yeah, but if it's working sufficiently, the effect on egg maturation is the same. If we are talking about the mechanism of maturation, the very popular is to combine ovitriol and decapeptyl together. Yes, and you will cover all mechanisms. You will utilize more natural hypophysis mechanism, but just in case you will have also ovitriol, and there are some investigation on this, and it from some aspects it could be very useful, especially in poor responders or empty follicle syndromes. Yeah. If you would like to have, I may make my answer simply. Yeah, I know about it. If you would like to have more mature eggs, combine both drugs.
And excellent. Thank you so much for yet another thorough answer, of course, to this one. And of course, there is thanks from the patient. And as I mentioned, there are like two questions left, and we will be finishing. So let's have a look at them. I'm also a patient of your clinic. I have now had four fade, fresh, and frozen transfer, all embryos, one XP, sorry, not sure. My age is 30 now, 39 now, and I always have 11 plus lining and good progesterone day of transfer. Is there any test I should do for my next round of my own
Mhm.
eggs?
I'm not sure about the genetic testing on embryos, so it could be one possibility to do the genetic testing on embryos, and I don't know about any immunity test will have been already done. Yeah, so it could be talked about in case of failure next time.
Of course, understandable. And remember that I will send you a link in a second, okay? So you will be able to simply go ahead and ask some more questions, or if you would like to get some more details. And I'm sure Dr. Pavel and his team will be more than happy to help you out with those as well. And now it seems that that might be our last and final question for tonight. If you do a progesterone test 7 days before transfer and it was too high and you decide to cancel the transfer, what would you recommend to do or change for the next cycle to make sure that that progesterone doesn't get too high too quickly? Is there any medication to keep the
Mhm.
progesterone low until the transfer date?
Yeah. Mostly it is only on random, only bad luck because the progesterone is produced by small follicles in this particular cycle. So next cycle, probably the amount of follicles will be different, and very probably next time in completely different situation could be progesterone lower. But in case we have a patient, they have a repeatedly high progesterone, it's possible to do to conduct the protocol under down regulation. It means the injections down regulated your own hormones, including progesterone, and the premature elevation of progesterone is excluded.
And perfect. Thank you so much for yet another answer, of course, and your questions. And that was our final question. So thank you everyone for joining us, for staying with us. It's been definitely an interesting session. So thank you so much for very interesting questions indeed. And of course, Dr. Pavel, it's been a pleasure to have you back with us. So thank you so much for joining once more, for answering all the questions and helping our patients out here as well. And well, before we go, is there anything else you would like to add?
Me?
Yes, of
Yeah,
course.
I would like to say hello to all of you. Wish you good night, good evening, good day. Depends when you are listening us, and hopefully see you in better times talking about our COVID era.
Of course, couldn't agree more here. And let me, as you can see, do you think will be okay for frozen embryo transfer in January?
Yes. I think so. We here there is no limitation regarding government or European authorities. Only our effort is to reduce contacts. Yeah, so we are trying to do everything with the minimum controls. The patients are coming, ladies, alone if it's possible. We postpone frozen embryo transfer till December, January. So it's only what we did, and I think for now, from today's point of view, I think the January will be okay.
And that is definitely good to hear. So fingers crossed all will stay the same. So you will be able to still come to the clinic and of course get the treatments done as soon as possible. And I just want to mention that of course this link has been sent to you right now. So if you would like, just go ahead and get in touch with the team, and I'm sure that they will be more than happy to help you out as well. And well, just remember it has been recorded. So if anyone had any issues with the sound or anything else, you weren't able to simply join, you will be able to see it tomorrow on our website, myivfanswers.com, with the link I have just sent to you. And of course, it will be uploaded on our YouTube channel. So go ahead and subscribe. That way, when the video is uploaded, you will know about it. And of course, we will be back here tomorrow at 8 p.m. UK time. And of course, there are plenty more events coming up. Dr. Pavel, thank you. Thank you so much for joining once again, for your time. I know it's quite late for you, so have a restful and relaxing evening, everyone else. I do hope to see you tomorrow, but also have a wonderful evening. And thank you once again. Take care.
Yeah.
Bye.
Yeah. Have a nice day. Bye.
Bye.